Sir, we are live now. With all your permission, I'm starting this session for today. Good morning, everyone present here. I am Faraz from IGCP Group. Welcome all the participants in today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Surnimal Mukherjee, sir. And let me share some of the achievement of sir. Sir has done MBBS, MS, DNB, MCH, and UK Orthopedics, orthopedic consultant at Lilavati, Bandra. And today, sir is going to discuss on a topic: recent advances in orthopedics. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here. Sir, kindly sir, turn on your camera and audio and share the screen, sir. I think sir is some facing technical issue, and I request all the participants, if you have any question related to this topic, you can put it in a comment box. And once sir start the presentation, after the presentation, he will take all the questions and answer all the doubts. I once again request all the participants to be here patiently. Sir, I will ask, could you please unmute yourself and start this presentation? Hello, sir. Can you hear me? Hello.
Is my voice audible now?
Yes, sir. Yes, sir. Sir, your network is too poor, sir. You can turn off your camera and present. Hello. Hello, sir. Hello, sir. Please turn on your camera.
Hello. Okay.
Sir, your screen is freezed. Sir, your screen is freeze, sir. Could you please open the presentation, sir?
Yes, sure. Is it visible now? My presentation?
Yes, make it full screen, sir.
Yeah. And okay.
Sorry. Sir, you can turn off your camera. Your network is so. You can proceed now, sir.
Okay. Okay. All right. Yeah. So my topic for today is recent advances in osteoarthritis. I'm Dr. Sunnimal Mukherjee. I'm consultant in orthopedics practicing in Mumbai. So in the first thing which we normally discuss in orthopedics in recent advances is a very common topic is stem cell. So stem cells have been researched since a long time, and they have a potential to regenerate into any form of tissue, and it has been studied in osteoarthritis as well. And the potential use of stem cell in osteoarthritis is that we want the stem cell to get to regenerate cartilage. So, however, it has been seen that till now we don't have a technology we can actually regenerate the cartilage using stem cell, a good quality cartilage using stem cell. However, what we know about the cartilage is that it contains almost 70 to 80% of water, chondrocyte almost 1 to 2%, and extracellular matrix almost 19 to 28%. So the thing is that in a cartilage tissue, there is a the cell count is only 1 to 2% instead of a very high concentration of cartilage. So with stem cells, it is very we have not been able to yet regenerate a similar pattern of cartilage using stem cell. So, what are the various options which we have currently? One is autologous chondrocyte implantation. So, what we do is that we take a cartilage cells from other site of our body, and we culture the cartilage cells artificially in over a period of 6 to 8 weeks. And after 6 to 8 weeks, we can implant these chondrocytes, which are regenerated in artificial medium, into the defect in the cartilage. The second option is that mesenchymal stem cells are very easy to harvest. They can be easily cultured and proliferate, and they have a potential to specialize into any form of tissue. However, there has been it is invisible, but whenever we use mesenchymal stem cell, it has never been successful to in regenerating the cartilage nicely. However, they help in decreasing the inflammation in osteoarthritis, and also they have a immunomodulatory effect which help in reducing the symptoms with help of mesenchymal stem cells. I think a couple of companies they are manufacturing mesenchymal stem cells for as an injectable option for osteoarthritis, those who want to avoid surgeries. So, second thing about a common surgery in osteoarthritis for hip is total hip replacement. So, in recent advances, what we can discuss a few points that we have slowly understood the approach nicely with good results, with almost 98% success rate or 95% success rate in various articles they are seen. The key points of performing is a minimal incision with a good approach and good closure of the tissue. And now the standard hip replacement which we use, the wearing surface which we use in hip replacement is a ceramic head with a polyethylene liner. So what happens that the traditional conventional hip replacement acetabulum cup which were used, they used to be fixed in the acetabulum using a scratch fit, and with the scratch fit, a couple of screws can be inserted like it is visible on the X-ray to enhance the fixation. However, recent last few years we have an option of highly scratch fit surface, like you can see on the image that the surface is highly porous, and this helps in better fixation of the acetabulum into the implant into the acetabulum. So this material is called trabecular metal. So trabecular metal has been developed by various companies. Zimmer labels it as and is marketing it as tantalum. So they are called tantalum by Zimmer company. Other companies are making a similar material which are called trabecular metal. So, in hip replacement surgery, in seropositive patients, it's very essential to have a good precaution. The main key functions is that earlier HIV patients surgeries used to be very difficult. However, with the advancement in our technique, with the standard approach, we need to take proper precaution, we wear helmet, suit, and then perform using standard technique. where we can do a hip replacement surgery with very good results. So, in cases of very poor stability, where we expect that the stability of the implant will be poor, like in this patient, he was a hemiplegic patient with a severe arthritis of the hip and inability to walk because of the hip pain. We had a neurological opinion as well, where we decided to fix the hip first. The neurologist also advised that he is suffering because of the hip. During the exposure, we realized that the muscles are very frail. There were hardly any inherent muscle contraction because he had hemiplegia of the same side. However, the key function is that what we do in such cases is use a constrained liner. So the acetabulum and the femur head, they get locked in a constrained liner, like seen in the image. In the X-ray, you can see there is an extra ring just below the acetabulum cup, and this is basically a constrained liner which helps in preventing dislocation of the hip joint. So in cases where patients are having hemiplegia or poor muscle cover or the muscle scarring is there we can use this constrained liner with good results. So this is a very recent post-op X-ray, post-op video where the patient was able to mobilize. Earlier, he was not able to mobilize before this. It is hardly, I think, 6 to 8 weeks after surgery with good results. So 3D printing is another technique which we can use, which is recently available even in Mumbai. We can order for a 3D printing, where in cases of complex hip replacement or there is a bone loss in the acetabulum around the acetabulum, or there is a complex fractures of the acetabulum, we can do a 3D printing of the bone, and and in that artificial model we can actually check which size of the acetabulum can fit into the acetabulum, the host bone basically. And like in this image, you can see that there is the defect, supraacetabular defect is there, and in that defect, artificial metal can be made, like especially implant can be ordered using this technique, and then implant fits into the defect, and it helps in better stabilization of the acetabulum cup. So, like in the images, you can see these images are taken from an article, so they're not mine. So partial knee replacement is recently very commonly used. One of my favorite surgeries where we can do we can in cases of young patients who are having isolated medial compartment osteoarthritis, and the ligaments are intact, like the ACL and the PCL ligaments, they are intact, and also the MCL structure is good. We can do a partial knee replacement. The main criteria is that the ligament stability should be intact, and the second thing is that the lateral compartment should the cartilage wear should not be seen. If the lateral compartment cartilage is intact, we can safely do a partial knee replacement. A couple of advantages that we are not taking the bone cuts in the normal area. Incision is slightly less, recovery is faster. Post-operative patients, they can move faster, and another advantage is that the range of movement post partial replacement is also better compared to total knee replacement. So like you can see intraoperative image where the knee flexion is good and the stability is also good. So another thing, the traditional technique of the knee replacement was devised. You can say that it started in around 1970s to 1980s, and the conventional technique is a medial parapatellar approach where the incision is taken medially. However, recently, last few years, many surgeons they do the surgery without cutting the quadriceps superiorly above the patella. So the approach which is used is a subvastus approach, where the below the patella the medial parapatellar incision is same. However, just as we reach the quadriceps muscle, the small nick is taken at 90 degree, and the muscle belly as well as the suprapatellar quadriceps is intact in this case. The advantage is that post-op rehabilitation is better. Patients have good muscle function in the early post-operative period. Tourniquet is not used. Not necessarily we can use a tourniquet. We can do the surgery without a tourniquet, and it causes less post-operative pain, less wound complication without using a tourniquet. So recently, there is a very common implant which we use for knee replacement. It is commonly called as gold knee. So the reason why it's called gold knee is because there's a coating made about the implant. This coating is basically titanium nitride, which is used in industries uh, to prevent corrosion of the implant. It has been seen that it is an inert material and very safe to use inside our body as well. So there is a special coating is there, and it looks yellowish in color, shiny yellow. That's why it's called gold knee. And there is a debate that what's the use of gold knee versus traditional knee. There are many articles which suggest that the amount of metal ion concentration in the synovial fluid after using a gold knee is much less compared to a traditional conventional knee replacement. Again, there's a debate that why to use a gold knee is slightly expensive. Around it costs around 15,000 to 20,000 rupees costlier compared to conventional knee replacement. But in patients who have a metal allergy or in patients with a kidney failure, there is a potential benefit with this. Further research, further studies need to be advanced on this, and they can be studied further. So there is many surgeons in Mumbai. They say that one of the best implant are coated implants, and there's another coated implant which is available. Is a say oxinium coated implant. Oxinium is basically a kind of a ceramic material which can be coated above the traditional knee replacement component. It looks black in color, like you see in the image. This oxinium knee also can be used in metal allergy in young patients who it makes the implant more harder. That's what the artificial studies this suggest, and the long term results are also good with hardening with this coated implant. So earlier knee replacement was traditionally a surgery after 60, 70 years of age. Even during 40s and 50s patients, doctors used to advise against knee replacement and used to manage even very severe bad patients conservatively. However, the concept has changed, and it has been seen that they have got excellent results at 20, 25 years follow with almost 90 to 95% survival. However, that's why the even younger patients are nowadays having the knee replacement surgery. Younger, I mean around in their late 40s or even in the early 50s. Many patients are having the knee replacement surgery with very good results. And it's not essential to have a knee replacement for each and every patient. In younger patient, there is option where we can use cartilage regeneration. MRI is needed, especially I do an MRI, especially when there is an isolated middle compartment osteoarthritis. If there is a tricompartmental osteoarthritis, then I think just X-rays and clinical examination should suffice. So, in cases of younger patients with cartilage defect, arthroscopic debridement is a process where we can debride the meniscus, we can debride the cartilage, and the patients they have symptomatic improvement. Many studies are there which show that the improvement is almost 50 to 60%. It is not as good as a knee replacement or any other cartilage regenerative therapy. However, if the patients are symptomatically better, we can delay the process of any other intervention. Cartilage microfracture is another option where we can create microfractures in a cartilage defect area, and it helps in regeneration of a fibrocartilage in that place. And the fibrocartilage also gain and decreases symptoms of osteoarthritis. Another use is a use of a robotic knee replacement. So many companies are, all the respective companies are making their own robotic system, which is feasible with their implants. And this robotic, the image is of Depu Synthes company, Depu company from Johnson Johnson. So they have a robotic system where the alignment of the implant is perfect. The bone is you can see on the image that the bone surfaces are well marked on the computer. and we can calculate the amount of correction we can, and the robot then guides how to take a cut in such cases. The advantage is that we get better alignment. So better alignment, there are less chances of any other complications like patellar instability, post-operative pain. It helps in and apparently it helps in decreasing the post-operative intractable pain, which is there in almost 3 to 5% of patient, and a better long-term outcome is expected with this. There are few articles recently which have shown that the intermediate outcome is not, there is not much difference between robotic and non-robotic. However, we are yet to have long-term studies with robotic knee replacement. So, like in this image, we are planning for a correction of the deformity. So, 2 degree varus and this is a diagram, a schematic representation. How do we plan in a robotic knee replacement? And many patients, they were earlier told not to flex the knee beyond 90 to 100 degree. However, recently it has been, many doctors are advising that they can be comfortable even after procedures. If they want, they can flex the knee as much as possible. It varies from patient to patient. There is no recommendation as such. However, but whatever I do is that I advise patients that whatever you are doing before, you can at least try doing it. If it's causing pain or any difficulty, then go slow, then try to avoid those things. I do advise against squatting down on floor. However, if they want to sit cross leg, if you want to flex the knee beyond 90-100 degrees, I think if you are able to do, can do it. Physiotherapy does help in postoperative period. And like I said, that few patients, they do complain of intractable pain. No cause is found of knee replacement. Apparently, the latest techniques, the use of a subvastus approach versus without not using a tourniquet during surgery, and better alignment with using robotic surgeries. All these things, they do help in decreasing the intractable pain.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants. Sir, could you please turn on your camera, sir, so that we can take these questions? Hello, hello, sir, you're on mute. Hello, hello. Sir, join with audio, sir. Yes, sir.
Yes,
Turn on
yes,
your camera, sir. Turn on your cameras.
yes,
Click on that camera, sir. Yes, sir.
yes.
Thank you so much, sir. Sir, we have received some
Was I
questions, sir.
audible?
Yes, sir,
Like,
you
was
are
I
audible.
audible during the?
Yes,
Okay.
sir. Yes, sir. Sir, the first question I will be taking, sir. Sir, from Dr. Agarwal, what are the latest advancement in the regenerative medicine for orthopedic application and how they are influencing patient outcomes?
So regenerative, like I discussed in stem cells, there are two options which we are having now. One is the mesenchymal stem cell, and one is the autologous chondrocyte implantation. So there are two different techniques. Autologous chondrocyte implantation is basically harvesting cartilage from a normal site and then harvesting it in artificial culture for over 6 to 8 weeks, and then we can implant this chondrocyte into the area of the defect. It creates a cartilage which is not of very good quality as a normal cartilage. However, it has been shown in many articles, and many surgeons have shown clinical evidence that they have got good results in many patients, especially in younger patients. They're having good results, less than 40 years of age.
Thank you so much, sir.
Thank you.
The another question is from Dr. Subramaniam. He is asking, sir, how are the new imaging modalities such as advanced MRI and CT techniques improve the diagnosis and treatment of the complex orthopedic injuries?
So definitely in any orthopedic injuries, CT scan and MRI is one of very common thing. For fractures, for bony conditions, to study the anatomy of the bone and the pattern of the fracture, CT scan are better. If you want to look for any soft tissue involvement, like the status of the cartilage, status of the collateral, the ligaments around any bone, what is the, if there's any tendon injuries or muscle injuries, soft tissue studies are better on MRI.
Thank you so much, sir, for answering all the questions, sir. As I can see, sir, there is no more question. I hope, sir, you have explained really well and done justice to this topic. As there is no more questions, sir, with all your permission, shall we conclude this session for
Sure,
today?
sure. Okay.
Thank you so much, sir, and we would
Thank you.
like to see you in future also with different topics. Till then, take care
Definitely,
of it.
definitely. Thank you.
Thank you, sir.
Sorry for getting late today.
No
Uh,
problems.
Just
Thank you.
connecting issues and the laptop issues were there. Sorry.
No